Top Med Talk.
Well, welcome to Top Med Talk.
We
are at the American Society for Enhanced Recovery here in Washington, D.C. this spring of 2019. I think it's the 5th or 6th annual meeting. I'm Desiree Chappell, host of Top Med Talk and managing editor, as well as hosting roundtable discussions here at ACER. So, I am joined today by Korey Springman. She is an anesthesiologist from Duke. You're a perioperative medicine trainee, right, Korey?
Yes, I'm a perioperative medicine fellow, but with anesthesiology at Duke.
Gotcha. Well, thank you so much for sitting down with us.
Having us.
We have a friend of the family, Miss Vicki Morton. She is
Hello.
That's
well
right. Vicki's co-hosted with me several times now on Top Med Talk, and thank you again for joining us.
Absolutely, anytime.
And we have a new friend from USAP, which is U.S. Anesthesia Partners.
Yes.
From Colorado.
Yes.
Courtney, tell me your full name, where you're from, and yeah, just give us a little bit of background.
Sure. So I'm Courtney Fossen. So I am in Denver, Colorado now, originally from California. So started my nursing career, 20 years ago. Started as an ICU nurse. And then I moved to Denver and I started in women's services and mom-baby.
Oh, okay.
Yeah, was a nurse there. And then when I left there about a year and a half ago, I was a director of women's services. And so now I'm in this role at USAP. And so I have learned so much in 18 months.
Yeah. What is your current title then?
So, Manager of Perioperative Services.
Manager of Perioperative Services. Okay.
Yes. And
so what made you make the switch? Like what?
Yeah.
What was your background in perioperative medicine? Because coming from mother baby, I would see that.
Yes. So I didn't have, I would be in the OR at times during C-sections and things like that. Spent some time in the OR when I was an ICU nurse. But I was just ready for a change and was somewhat looking to get out of the hospital setting just to have more predictability. And so this opportunity came up and I took it and I could not be happier.
That's awesome. Was it a new role that they had just kind of developed?
Yes. So, USAP is national. So we're in about 8 states. And so USAP Colorado is the first platform to have this position.
Had you heard of perioperative medicine before?
I had, but I didn't know much about it.
Yeah. It's such a loose term. It seemed like when I first was introduced to it.
Yeah, I knew more just about the intra-op and post-op. I didn't really know anything about pre-op. Yeah. And of course, I'd never heard of ERAS.
Yeah.
So I got quite an education on it.
So huge learning curve with the perioperative medicine and the ERAS component.
I was thinking the same thing.
Yeah. When I started, I think, we had a handful of pathways, maybe 10. And I think now we're up to somewhere around 26 over 15 service lines.
That's fantastic.
Holy cow.
Yeah.
So when you took this position, because I get this question a lot, and I know, Vicki, you do too, about like ERAS coordinators and perioperative coordinators and things like that. And so someone had already started enhanced recovery protocols or pathways.
Yes, anesthesiologists did.
Okay.
So we had we had the chairs of our perioperative services home committee, which were 2 physicians. And so, they started this, but of course they didn't have the time to put in and to attend all these meetings and the nursing education and all of that. 2 people just can't sustain that. Yeah. So, and we had our quality assistant, Ashley, that helped, and our director of quality that helped. But it just needed someone that was strictly devoted to that. Mm-hmm.
Yeah, and pulling that all
pull it all together and organize it. Absolutely. And I think it helps having of course, being a nurse, but having a background of working in a hospital and doing nursing education and knowing what works well with nurses and knowing what they need.
Exactly.
So all of that was the easier part. So, but I started, I went to my first conference, which was an EBPOM, and learned a ton there. Yeah. And so then I've just been going ever since, and every time I learned something new.
It sounds like you have a lot of support from your organization.
A ton.
Can you tell us about that?
Sure. Because this is what, the hospitals are our customers. Mm-hmm. So, and this is something we can bring to the table.
Absolutely.
So it doesn't take out of their resources. So I'll go in and do nursing education, physician education, different things like that. And that's a help to the hospital because they don't have people sitting around waiting to do that. So, and I think because ERAS has grown so much, we've been able to show the data. We show the data back to the facility. And so that only increases our stickiness with the hospital, which then I think that's why I get so much support, because I can show, hey, we've decreased this much in narcotic usage and length of stay. And so, and it changes, right? ERAS changes. And so, this is, for me, I go to a certain amount of conferences every year, and that's all budgeted for, and that's supported by my organization.
Yeah. So I know that I've learned with my hospital system, having the relationships with the hospital administrators and having those meetings and presenting that data. And just like you said, Keys, it's kind of taking it off their plate. They don't have to do it so much, but they're involved. Do you find that, that relationship has grown tremendously since you started your role, and that it's beneficial to you and helpful to you and your group to getting things done in the hospital? Do they help you with that piece?
Absolutely. And when I first started, I would rarely go to a C-suite meeting, and now I attend every single one of them.
What is this?
Because they want to see my data.
What kind of meeting?
The C-suite?
Oh, so like the executive staff.
Okay.
Yep. The CEO, CMO, CNO, because they want to see the data. So, and they want to see what's happening with their patients, and it's become one of their top priorities, especially, with the opioid crisis. So, and just to see that reduction, in what we're doing.
Yeah. So you said you have now 25 hospitals, correct?
Something around there that we serve. Yes.
Okay. So do you...
Between surgery centers, hospitals.
Sure.
Gotcha.
Okay. So as far as the ERAS component goes... in 25 hospitals as far as ERAS goes.
Yes. So it's in about 15 hospitals, and then we have surgery centers that have some pathways. So, we've done a few pathways with surgery centers.
Yeah, we just embarked on outpatient surgery center, hysterectomies and gynecology, and we're working on the same-day total joint in the surgery centers now. So I think that's a whole area in of itself that's going to be up and coming.
Yep.
And I know personally I need to learn more about it. And so I'd actually love to talk to you more about that, because
we have one.
You just...
you two very much mirror each other.
There's a lot of similarities.
Definitely. But I am hearing more and more about the surgery centers and people embarking on that, and also office-based anesthesia and wanting to have components of enhanced recovery in those types of settings, which I think is fantastic. It's not just about, the inpatient, how we can really impact patients of all kinds.
Absolutely.
Courtney, I have a question. So, we hear a lot of these programs. Either they start grassroots movement, a couple people are wanting to get this up and going, like an anesthesia provider or a surgeon or something. And then, those people are always like, oh, we have no top-down support. We can't get anything done. But then we also have, we also hear from you guys that have like this amazing support from your groups and the hospital. What are some of the challenges that you feel that are unique to that type of kind of approach to implementing enhanced recovery? Does that make sense? You know what I mean?
Yeah.
Because I think that those challenges are different. And I think we have listeners that come from like every angle.
Yes, absolutely. I mean, there's a difference when you have, we have like 5 hospitals within one system, and the support at each facility is a little bit different. And when you really have, I was just in a meeting with the CNO of one of our facilities, and her big priority is helping to form an ERAS committee. So that's huge. And so that system or that hospital will be more successful. As opposed to when you don't get the same support at a different facility. So really, that has made a difference. And it'll be interesting to see how far we come there, at that facility versus a sister facility where we don't necessarily have that same support.
Yeah, so I've run into that. And what I found really is the support from Director of Perioperative Services, and getting to the individual nurse managers has been so helpful. Some of our hospitals, the CNOs, very engaged, want to absolutely run with it. Some they'll give you whatever you need, but they want hands off.
Exactly.
And so it's all about finding those right people.
Absolutely. And then getting them all together,
Yes.
right? And then not forgetting about anybody, not forgetting about pharmacy and IT and, always having a nurse champion. And that's been really successful for us. Yeah. And we used to just start with having like a floor nurse champion, but now we've learned to have a pre-op champion and an intra-op and a PACU champion. That has been huge. And interestingly enough, a few weeks ago, one of my PACU nurse champions sent me this spreadsheet of data, and it was probably the best data I've ever had, because she literally got 15-minute pain scores and nausea and every single thing that went on with this subset of patients in the PACU. And I didn't even ask for that. But she did it because she wanted to see the type of impact that was making.
That's wonderful.
So, you can mine, data out of the computer, but I mean, that was real time, actual, getting it straight from the patient's mouth.
Absolutely. And it's one person who's collecting that data, and it's
right.
It's more consistent, provides a better picture.
Yeah, absolutely.
One thing I found, just like personally in my experience, is like finding those people.
Absolutely.
And making them your champion, because it's not enough because the order just say, oh, I'm going to put Susan as the the person in charge of this. Well, Susan really could care less about it.
Exactly.
And Susan will never care about it.
Yeah. And
no matter what you're doing.
At this particular facility, I worked with the director of the whole surgical services, and she had some just nurses that were really, they wanted to do posters, and they wanted to, so that's who did this, so she kind of connected me with her, and I mean, she can't get me enough information. Yeah. So, and it makes a huge difference versus someone that's not as engaged.
Yeah, absolutely. And hopefully those people are recognized in other ways besides just like their own personal growth, but like the hospitals.
Oh, absolutely. Yeah. Especially at magnet facilities. And,
I was just going to say that.
Most of ours are. And so that's been really helpful. You have
clinical ladders.
Yep.
Yeah. And
I know we've had that conversation a lot, Vicki. You've told me about how like you're like, we need to do this poster. Yes. And one of the things that I think is if you're a great leader in this, that you learn to bring other people along.
Mm-hmm. Absolutely. And what's amazing to me is how many nurses have never engaged in that before. Yeah. So I started just writing abstracts and submitting them to various, nursing organizations for presentation, and they all got accepted. And then I would go to the floor and be like, okay, nurse, you've been the champion here. This was accepted. Could you go and present this? And their nurse managers they love it. The nurses have loved it because it
empowers them.
It empowers 100%.
them. And that's something that we all need to feel empowered within our jobs, and to feel that we are adding something to the outcome.
Yes. I think it's important for nurses to have that experience and just to be able
to grow and develop. And,
yes.
Yeah.
We talk about that a lot. We just sat down with some of the CRNAs that have been active in this space as well, and reaching out to those that are doing projects, their DNPs and things like that. And so, like, if you're a surgeon, you're wanting to get this started, or you're an anesthesiologist and want to get it started and can't get other people, find those. I mean, you can go to those other people, specialties that are wanting to do furthering their education and things like that, and they can help you. Absolutely. Like if you have limited resources.
Yes. Yes.
I think that's one of a good way to be able to do that. Do you have any other suggestions, like when you're working with a facility that you feel like kind of has limited resources, some of the other things that you've done? Creative ways to...
creatively, I've just... I've attended staff meetings. So, if a floor does, like if we don't have an ERAS committee, then I'll find out, like when we instituted a specific GYN pathway. So I found out when their meetings were going to be. I attended. I gave information on ERAS, like what it looked like for a floor nurse. I also, PACU or all of periop is hard to get in front of sometimes. Yeah. So, I found a good time. They set me up in kind of in between PACU and pre-op, and nurses just came as they could. I brought food and candy, which, is always helpful.
Always. So we did too.
Yeah. And we, our anesthesiologist, who's very engaged in that pathway, agreed to be there as well. And so I think for them to have that interaction and to see our anesthesiologist so engaged and so passionate about this, I think was very helpful. So that was really well received. And now we're rolling 2 more pathways out at that facility, and they've asked us to do the same thing because their staff felt like it was really helpful. There wasn't an educator that could take, all this time and do that. So we just had to kind of just figure out what was going to work best for the facility and help them with that.
Yeah. Have you found any other leaders besides the anesthesiologists within perioperative medicine and enhanced recovery that are successful at leading the
charge.
The rollout?
Yeah. I mean, I think our leadership within, peri-op services. So, and I think and that just kind of depends on, where their goals and everything like that lies, but I think once you show everybody some of the data, nurses aren't having to medicate patients so often. It's actually decreasing their workload.
It is.
So a lot of it is those nurse champions, and then people, they start to talk about it and people start to hear about it, and then they wonder, well, why aren't we doing this for our patients? I mean, it's so different now how we care for patients, and I think those people help lead the charge.
I've noticed when I do so our nursing education is a little bit different. It's all done the exact same way. And so when it's being rolled out in a new hospital or a new unit in the hospital, what have you, it's a 45-minute mandatory education session. It's the same nursing education slide deck. The only thing that varies is obviously the protocol in which they're being educated on. But they have to attend. And I always get the looks in the room, or the nurses make comments of
what are you trying to do?
They do. And like the ambulation, we don't have the resources. What do you mean we're feeding them right after surgery? All these things. And I say, don't worry, I promise you, in a couple of weeks after you've taken care of these patients, you will see that they do better. They're easier to care for, and actually it is reducing your workload. It doesn't sound like it right now. And when I go back and I round on the patients and I talk to the nurses and they say, yeah, no, you're right. It's much easier to care for these patients.
It'd be great to see a before and after, almost.
Yeah, and it's interesting because the first conference I attended, I heard you speak, and you said, tell them first it won't increase their workload. Yeah. And so I took that as because
you have to manage the expectations.
You do, because the last thing you want to do is add more to a nurse's plate. They're very, very busy. And so I'm glad to hear that about your education. We're working on standardizing it, and I think that'll make it a lot easier. It's just taken a little bit of time.
It does. I tell the story a lot frequently, is that I had it was actually a CRNA DNP project, make this education piece for me, and so that was it, and that's what we use as our education piece for nursing. So you have someone else do it. It doesn't have to be you. You vet it all. You tell them what to do, but they can make it for you, and so then you're taking. Someone else is taking an onus for something. They can take
part of their project,
and it's part of their project. They get something out of it.
Yep.
You get something out of it because you're doling out your divvying up resources and things like that, and delegating, and that makes everybody's job easier.
And one interesting thing, one of our anesthesiologists, his daughter's pre-med, and so she's coming home for the summer, and she's going to do an internship with one of our
that's awesome.
cystectomy surgeins to help with this data. So
I was just going to say the millennial that can do your data.
Absolutely. So when I heard that, I was like, yes, we don't. It doesn't take anything away from us, and she'll get a great experience out of it, and we'll get some great information.
Well, and hopefully you'll have another perioperative physician that's coming up through.
Yes, absolutely. That would be great.
Ranks.
I used a pharmacy intern. They had one there. I attended a meeting for the opioid stewardship to present data, and I needed help to try to capture some things, because I wanted to present it to the surgeons so that they would take note of how few patients are actually needing opioids on the floor, so that they're not prescribing for every single patient. And so they're like, we have this pharmacy intern that will be here for an entire month. And it's a great idea. We'll give her to you, and you guys can work on that together.
Amazing.
I'm like, thank you. And it was so effective.
Yes.
We have totally decreased the number of prescriptions going out the door just to make the surgeons aware and force them to look at what actually their patients are taking or not
when
taking.
you can show them that.
Yes.
Yeah.
Makes the biggest difference.
You know, I mean, the opioid crisis is, I mean, for people in enhanced recovery, and if you want to get a program going, that it's like a low-hanging fruit.
It is. Oh, yeah.
You know, I mean, you can do multimodal pretty easily. You know, people understand it once you kind of get into it. I mean, it's not really abstract. It's pretty concrete, you know, and you can show immediate results with it, too.
Absolutely.
You know.
I could speak to this. This is a different angle, and this was something that I experienced with being a resident physician as well as now an attending physician fellow at Duke. Residency elsewhere, but changing the perspective and of how do you treat pain? And a lot of times it was an education background that we are so used to always going to the fentanyl or to the hydromorphone, even in our PACU still, or in the ICU. And we're all charged on every level, from the person who greets the patient that comes in the door all the way up to the CEO of the hospital, to limit the amount of opioids within society. So yes, it's a very low-hanging fruit, but it's also just changing what we've done for so long. And sometimes it's hard for people to recognize, like, that little dose of this opioid here, like, give them so many more tools to utilize that are no longer opioids. And that's what I try to encourage our nurses in our ICU at Mayo with cardiac enhanced recovery, because they were just used to a fentanyl PCA. And I was like, no, you'll love this because you'll have so many other tools that you get to use, and you'll find which one works best for which type of pain. And they finally caught on in it, and they've done a really good job.
What was one thing I found really interesting is we have a GYN pathway at a certain facility, and the nurses, one day when I was there doing some education, they wanted to get rid of the PCAs. They didn't feel like the patients were using them. And I can understand that. I mean, PCA is a pain to set up. You have to, exactly. And so we went to the GYN surgeons and asked if we could trial this. And we got rid of them. And they saw, I mean, their narcotics decreased so much, but their pain scores remained unchanged. And so the nurses noticed this, came and asked for it, and those patients no longer get PCAs.
Yeah, I love it. Frontline providers are going to be some of your biggest assets and have some of the best ideas.
Absolutely.
If you just sit down and listen to them. Really take the time to do that. Shortly, because we don't have too much more time, but I did say I wanted to talk to you about your spine protocols that you're doing, and like kind of the chronic pain patient, because Vicki and I, we talk about this all the time. How do we manage the chronic pain patient in these ERS protocols, because it's not frequently addressed.
Right.
So spine patients, we know, are kind of a beast sometimes to take care of. So what has your experience been?
So, we just started this in February at one of our facilities. We have a couple of spine protocols, but nothing that is this in depth. So we worked on this protocol for a year. And it went through everybody in every committee you could possibly think of. And so we started with one physician, and it's for multi-level spine fusions with or without instrumentation. And so I think the biggest component to this, this program has a nurse navigator, so that, and she is the one, the patients have to attend mandatory joint class or spine class, so it's not an option. So
it's like a joint, they're setting up like a joint program.
Yep.
Essentially.
Absolutely. And so she does the education with them, and I think the biggest takeaway she has shared with me is that she sets expectations. You're going to have pain.
That's huge.
And here's how we're going to manage it. Here's what we're going to do first. And you can't expect to have no pain. It does need to be bearable. The reasons we don't want you to take a lot of opioids is A, B, C, and D. She gives them all those reasons, talks about their recovery. And so these patients are more educated, I think, than any patients I've seen, just because of what she goes through with them. And so they come in. So we do IV methadone. Intra-op.
Is that as a bolus?
Yes.
Okay.
Yep. We do it intra-op. We also do Exparel. So as a field block.
Field block. Okay.
Yeah. And then, these patients are, that we do have if the patients are in PACU and having severe pain, we do have a methadone protocol that's only for really severe pain.
Like a rescue.
Yeah. And we don't do it past the PACU. But then, the patients go to the floor, and what we've seen, and I think we're up to like 15 patients now, is they started with a mean length of stay of like 5 days, and it's 2.6.
Wow.
Now,
That's
and
huge.
Our narcotic usage has been cut by 40%.
That's fantastic. Yeah.
Absolutely.
Yeah. And so, in fact, one patient went home with not taking a single opioid after major back surgery. Wow.
So your chronic pain patients that you have come in that are already on things, I get this question almost invariably every time I talk about it. Do you keep them on, like, do you take them off their meds? Do you start them on methadone? Do you like, what do you do? Do you just, like, for us, any chronic pain patient that goes through an ERAS pathway, we were just keeping them kind of on their homeostatic dose.
Yes.
Like you take 4 a day. Stick with that.
Yes.
But is that what you guys are doing, or?
Yeah, and we're they're really thinking that this intra-op methadone is helping with that. Mm-hmm. And helping to where they don't need so many opioids after the fact,
Sure.
As well as the longer-acting Exparel. So, but typically, yes, they are on opioids prior to coming in. And so, but I think also this particular surgeon, is very mindful of that and talks to his patients a lot about that.
It sounds like almost every place that gets implemented, there's at least one surgeon who's the leader, or
we call him our champion,
the instigator. Almost.
Yes.
And did they bring you in at that point? I mean, it's just for me trying to understand, because you guys go into hospitals with different pathways.
Yeah.
Were you already with this hospital?
So we've been at this hospital, and typically what happens is one of our anesthesiologists will come to me and say, hey, let's start a pathway at X, Y, and Z hospital. Mm-hmm. And so since they know the hospital, I ask them to get a surgeon champion.
Gotcha.
And then I work with the hospital to get a nurse champion and everything like that. And so interesting with this spine pathway, we just started with one physician. Mm-hmm. Sometimes I found that to be a lot easier.
It definitely
They've talked about starting pilot program.
Yep.
We've heard that a
so
ton.
that's what we call it.
Small.
Yep. We say, let's start a pilot.
Yep.
And so we were going to add others in 6 to 9 months down the road. Well, a month after starting this,
everybody wants to do it.
Yep, of course,
Vicki,
of course.
So that's just kind of what we found. And so, if I have some surgeons that aren't willing to do it, I don't worry about it, because I know down the road they're gonna see the results. Totally, absolutely. It's like that. Yeah,
win by winning.
And if they don't, they usually are not that they don't do as many surgeries anyway.
Absolutely,
Right.
Absolutely.
And we have some surgeons who've refused to participate in the program, and I'm like, that's fine. I can't bring them on fast enough, because they are, knocking down my door to come on, and they all have to go through the same process of coming on board. It's not just, I'm going to post this case now as ERAS. They have to go through a process. But if they don't want to participate, too bad for their patients.
Exactly.
But it'll come in time, because it's going to be mandated either way.
Absolutely. Yeah, absolutely.
Okay, so we literally have just two more minutes, but because I have 2 enhanced recovery coordinators here, we get the question all the time about how would you describe your job, and if you were making a job description, because a lot of people are wanting enhanced recovery coordinators. What would you say are the top 3 things that you put down as in a job description, Courtney?
Data analysis, evidence-based research. I do a lot of research, and really just being that resource.
Expert communicator.
Yeah, and communicating with different you have to communicate differently with a surgeon and versus nurses versus, it runs the gamut of everybody, and every person in that hospital is important in your ERAS pathway. It doesn't matter what their role is, they somehow impact your patients. Yeah. So you just really have to be open and willing to kind of juggle a lot of things in the air at one time.
Yeah. Vicki, what would you say?
I would agree with those. So I can't. It's just 3. I think really first and foremost, and this is why I think that former ICU nurses make really good
coordinators,
leaders of ERAS. You have to kind of just let things roll off your back and have this personality of going out and getting it and doing whatever you need to do.
Yeah.
And doing it efficiently and organized. So I think it's a personality trait almost. Mm-hmm. So I think that's really important. I think organizational skills is high on the list.
Very much so.
I mean, lots of hospitals, lots of pathways, lots of people. And probably, I'm not going to repeat the ones that you just said. I agree with all of them.
Yeah.
Really proficient at PowerPoint and Excel.
Delivery of like an educator. You have to be
being okay in public speaking.
Yeah, that's a huge thing.
You have to be able to do that.
You said you've worked with some people like they are really smart, they love it, they get really engaged, but they can't get up there and actually tell people about what it is, and you have to be able to do that.
You have to be able to.
Well, ladies, I literally think we could sit here for the rest of the meeting.
We could
and chat, but we do have to wrap things up. Hopefully, we can do this again. Courtney, I know we've been talking about trying to get to sit down on Top Med Talk for a while now,
absolutely.
and I really appreciate you.
Thank you.
Taking the time to do that, and Vicki and Korey, thank you guys so much.
Thank you for having me.
Appreciate it. So,
thank you, Desiree.
Be sure to. I've forgotten to say this on a couple ones. Be sure to listen on Top Med Talk. You can go to topmedtalk.com. You can subscribe on your favorite podcatcher. We're really active on Twitter and all your favorite social media platforms. So check us out there. Hopefully, we're going to be putting up some pictures, some content from Acer, maybe throwing in some video content here and there along the way. So be sure to engage. If you have any questions, give us a shout out on your social media platform or send us an email. I think that would be great. So thanks so much for listening, and we'll see you next time.
Right. Thank you.
Thank you.
Top Med Talk.
Nate Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com, and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.